The Behave framework and training grew out of actual experience around the world, enabling and supporting community groups in planning their own projects. It does not rely on a single behavioral theory, but allows for all behavioral theories. It's based on the statement, in order to help a specific priority group to adopt a specific behavior, we will focus on a few key factors that influence behavior through strategically focused project activities. Now again, don't let the simplicity of the approach mislead you into thinking that you can fill in all the blanks in your own head based on your own intuition. Each step requires research and analysis and creative thinking. So, a quick review of the first principle, which is captured in the first column of the Behave framework. Know exactly who your group is and look at everything from their point of view. The most common mistake in attempts to change behavior is to begin with your own point of view. What you've got to do is look at the world the way they see it. Failing to do that is how we have come up with so many wasteful and ineffective education and awareness campaigns, like the DARE program. You're familiar with that? Sending real cops with real loaded guns into schools. And not only does that not reduce illegal drug use, but it actually piques interest in initial illegal drug use. Yet they keep doing it. Isn't that astonishing? You can consider your target audience to be your primary audience, and you have secondary audiences too. Your priority group is your target audience. You seek a direct impact on their health. Perhaps for you, this group are school-age students who should have an asthma action plan. The supporting group or groups are those who will help to influence the priority group members. And they could also be people who currently pose a barrier to the proper behavior, or those who are in a position to make the behavior easy. For example, the parents of those kids. If your goal, for example, if your goal is to keep kids from smoking, the single most important primary audience is their parents. Another important primary audience, however, are cigarette sellers, and that's why we bust them for illegal sales to kids, because if you're willing to take away their licenses to sell, that really works to get them to stop selling to underage kids. Another primary group for tobacco control, obviously, is policymakers. The single fastest way to get people not to smoke is to raise the taxes on cigarettes and to clean up indoor air. In simply defining your priority and supporting groups, you're already talking about behaviors. Now, remember, social marketing is an iterative process. As you refine the behavior, you also refine your priority group. The contents of one column affect the contents of the other column. Target groups are never chosen in a vacuum, but in their social context. So let's focus on the first column. In the old days, public health interventions were only aimed at individuals, but it turns out that one of the biggest determinants of smoking is where you live. Dr. Tom Levista did some of this research that I'm reporting to you now. Smoking prevalence in Maryland is down under 19% now, which is an astonishing public health accomplishment, because 1/3 of all long-term smokers will die of it. But having such a low state prevalence doesn't tell you much about what's going on in pockets. In Montgomery County, it's down below 11%. In Tony Howard County, it's down below 9%. In the neighborhood around Morgan State University, where I teach, smoking prevalence among adult males is 69%. It was so incredibly high that they didn't even know they were supposed to lie about it. You know what I mean? It's so normative, they were honest about their smoking behavior. Now, that tells you a lot. Individual cessation programs aren't going to do it for us in Baltimore City. And programs and communications designed for Howard County and Montgomery County probably aren't going to work in Baltimore City either. Segmenting the audience means identifying a group of people who have enough in common that you can reach them or motivate them in an efficient way, and getting as specific as you can in describing whom you're trying to reach. The more precisely you can describe the group, the stronger your project will be. Again, the goal in segmenting is to reach the largest number possible who have similar needs and wants. Because remember, if you try to reach everybody in the same way, you'll probably hit no one. So here are 5 ways to describe a group. You could segment by demographics: age, income, geographic location, gender, race, language, employment. But you should never limit yourself to those demographic characteristics, because you might miss important clues about what makes people tick. People might have a common behavior. They may desire the same thing, or they may face the same barrier, or they may be at the same readiness of change point. One of the nice things about the stages of change paradigm, it was described to us by Prochaska and D. Clemente, and D. Clemente is local. He is at University of Maryland. This model made smoking cessation much easier for people who were running into the brick wall of pre-contemplation. People who were in the streets doing this a decade or 2 ago knew that not everybody was ready to quit smoking, but the government-funded programs were making them aim at everyone, sometimes even at the ones who were the least ready for change. So, just a quick run-through of what these stages mean. Pre-contemplation or pre-awareness are those people who have no intent to change. They are unaware of, or they deny the risk. In the safe sex paradigm, these are the people who never even think about condoms. The awareness contemplative stage are those people who know the problem exists and they're thinking about change, but they haven't made a commitment to it yet. So again, in the safe sex model, they know about AIDS, but they may not have thought about its relevance to them. In the preparation or decision-making change, there is an intent to take action. That is, they go out and purchase condoms. In the action phase, they are actually engaged in the new behavior. And that, for example, would be people who use condoms. And finally, in the maintenance phase, they maintain that changed behavior over a long period of time and prevent relapse. And if they do relapse, they get back on the wagon again. Now, why is this a useful way of segmenting? Because it takes different approaches to move individuals to the next step. Because using a condom the first time is a very different action from using them again. Different motivations and different supports are needed for movement to the next stage. And of course, when you're doing this work in the real world, you use data that you collect. You always check in with your target market, not just hunches, to make your decisions. You go first to sources of information that already exist, and this group is incredibly knowledgeable about asthma. You use those sources to learn as much as you can about your priority group, but you always check in with your priority group. You ask. And what you'll discover is that people love to be asked. They'll pour it out to you. There is a lot of information available about disparities in asthma risks, but it seems to me that the social change artists aren't really using that information to design their interventions. These are various ways of getting the information you need to fine-tune your plan, and these are extremely inexpensive. I hope you have graduate students on your teams, because you can send out armies of graduate students to do exactly this. So for the sake of illustration, I apologize, that's difficult to see. This BEHAVE framework is used to show that it can be applied to any problem that can be solved with behavior change. This framework defines as its priority group pregnant women in malarial areas who are not currently sleeping under a treated bed net every night. Now we're going to look at the second column, which is your bottom line, what your project is accountable for. Action is what counts. And the principle number 2 is what counts is behavior, not awareness. To illustrate that you can waste a lot of resources raising awareness, do you remember the extremely expensive and I thought very stupid Got Milk campaign? Actually, they used well-known celebrities wearing milk mustaches. I never quite figured out who was behind this anyway. I suspected the Dairy Council. It wasn't a health message. It wasn't saying skim milk. It was, well, there you have it. Anyway, when they went to look and see how they were doing in the Got Milk campaign, the fuchsia-colored line is the media buy. That was the money that they invested airing those ads. The blue line is people's awareness. Everybody was aware of the Got Milk campaign. The green line, the flat line right in the middle, is milk consumption. Well, heavens, how long were they going to keep that up? Look at how long that campaign ran, and nobody drank any more milk because of it. Duh. As a matter of fact, it turns out if you want to get people to buy more milk in the grocery store, you put it right next to the chocolate cookies. But the point is, if we change people's knowledge about HIV and they don't use condoms, we haven't really accomplished much. If we convince a health worker that she should counsel new mothers about breastfeeding, but she doesn't have the time to do it, it's not going to matter. This is what we refer to as the CAP gap. That is, the space between what people know and believe, their knowledge and attitudes, and what they do, their practices. Now, of course, ultimately, everybody in here is seeking better mental and physical health for the populations that you serve, and that's why we're in this business. But often, that's way off in the future. And think about smoking cessation. Those people are going to get extra years, but it's going to come at the end of their lives. And you don't want to wait around to measure that. All you can realistically hold yourself accountable for in the short run is the behavior change that you seek.